Hello, my name is Brian Barry. I am a neurologist and multiple sclerosis specialist at MedStar Washington Hospital Center and MedStar Georgetown University Hospital Department of Neurology. And today I have the pleasure of talking to you about disease-modifying therapy for multiple sclerosis. My talk is titled What People with MS Need to Know. So I like to start with a quote. And just to say, this is a sense of how pessimistic neurologists were as a field in the pre-treatment era, and kind of a hint of, where we're going to be going after this. And this is actually a quote from one of our multiple sclerosis textbooks from 1991 by a Dr. Matthews. And he says, "It is not easy to accept that after years of increasing endeavor, there is no immediate prospect of any treatment that can be relied upon favorably to alter the course of the disease." And so what he's saying basically is that they've tried a lot, nothing's worked, and we're frustrated. And mind you, this is 1991, so not too long ago. But you'll see in a second, it was just a few years after this that we got our first treatment, the interferons for multiple sclerosis. But just a few years prior to that, things were looking pretty bleak. And believe me, they tried everything. So really for almost 200 years, the MS community and MS patients were looking where they were desperate for anything that could alter the course of their disease in multiple sclerosis. And this is some information that I gathered from another one of our MS textbooks. But the MS field goes all the way back to the early 1800s. 1824 is when the first cases of multiple sclerosis were documented in the literature in Paris. And a few decades after that, Charcot, the famous neurologist, gave his first few lectures on multiple sclerosis. And from there, the field really took off. Unfortunately, treatment didn't keep up with the knowledge that was developing about multiple sclerosis as a condition. And if you were an MS patient in the 1890s, you were probably exposed to some pretty toxic stuff. And so they might give you a nerve tonic, but unfortunately these tonics were laced with poisons like strychnine and arsenic. And I can't imagine that they did much, really, for your disease at that point. A few years later, things didn't get much better. They were trying to treat syphilis with all sorts of things. Syphilis being another disease that was very prevalent at the time, and a disease like multiple sclerosis that can affect the nervous system kind of unpredictably. And they were using some pretty toxic things for syphilis at that point: mercury, silver iodide, potassium iodide. I don't think it was very successful for MS or for syphilis for that matter. Things started getting a little bit more palatable a few years later. They might start, shocking the back of your head with an electric current, or if that didn't go for you, maybe sending you to a spa bath. But unfortunately, those spa baths, they also applied leeches. A few years later, things started getting a little bit warmer in terms of what we would think of as modern medicine. And antibiotics were starting to come into practice at that point. And tuberculosis treatments were applied for multiple sclerosis in the 30s and 40s. Didn't do much for the MS. In the 1930s, there was also the first claims of a virus as a possible cause of MS. And while these early claims turned out to be essentially false and not able to be replicated by other scientists at the time, this idea that a virus could be the cause of multiple sclerosis really persists to this day, and modern scientists have a few viruses that they think could be actually one of the causative factors of multiple sclerosis. They tried a vaccine at that time and thought they had some data, but again, that data could not be replicated by those early scientists. Nevertheless, the idea persists to this day that maybe in the future a vaccine could be used to prevent multiple sclerosis. In the 1940s, we started getting really our first modern treatments that we still use to this day. So immunoglobulins were being used, and immunoglobulins are essentially antibodies. So they were giving you antibodies from essentially other patients in the hope that you would recover from your multiple sclerosis. And those of you who may be familiar with IVIG treatments, something that we actually use to this day occasionally for MS relapses, that treatment had its foundation in the 1940s when they were using immunoglobulins. They were also using blood thinners at the time with the hope that thinning the blood out would actually have some impact on multiple sclerosis. And while that probably didn't have any effect, Similar to the idea with viruses as a cause for MS, the idea still percolates in some scientists' heads at this point that maybe the vascular system has something to do with MS. And that's because those spots, those plaques, those lesions that happen in the brain and spinal cord of MS patients tend to occur in the areas around a blood vessel. Very interesting. We don't really know entirely what that means, but it's interesting that in the 1940s they were using blood thinners to try to treat multiple sclerosis. Soon after that, though, the first breakthroughs started to happen. ACTH, the body's hormone that releases actually steroid hormones, was being injected into multiple sclerosis patients. And this is still a strategy that we use today occasionally to treat multiple sclerosis relapses, by injecting ACTH, causing the body to naturally release steroids. A few decades after that, they started getting the first steroids, the first modern steroids, things like prednisone and IV steroids. And any of you who have been treated for an MS relapse would be familiar with those, certainly. And steroids remain, to this day, kind of the mainstay of relapse management in multiple sclerosis. Not so much disease-modifying therapy, where we're talking about preventing future disease, but actually shutting down inflammation when it's happening in a relapse. A few decades after that, finally, we got our first breakthrough that actually impacted disease-modifying therapy. These were the beta interferons, and they started to be studied in multiple sclerosis in the 1980s, and finally, in 1993, interferon beta was FDA approved for the first disease-modifying therapy in multiple sclerosis. So all in all, that's almost 200 years of trying before we got our first therapy, and things have really exploded since then. So here's another quote, just a couple years after that first quote I showed you, and this is by Dr. Arnoldson in Neurology, our journal, in April 1993. And this came out in the same issue where they published those first studies showing that interferon beta was effective in multiple sclerosis. It was an editorial that this guy wrote. He said, "The natural history of multiple sclerosis has been altered favorably, substantially, and above all, safely. This is, I believe, the end of the beginning. Whether it is also the beginning of the end, time will tell." So this is very optimistic. He's saying essentially that after all those almost 200 years of trying, we finally have something that works. It seems to work substantially, and it seems to be safe. And he says, this is probably not the end of the road. This is, the end of the beginning. And he anticipates that there was going to be an explosion of MS therapies that were going to come in the next few decades, and he was right. So what is multiple sclerosis? It's a simple question, but very difficult to answer. Because really, if you're going to modify the disease, you have to first understand what's causing it. And so I've listed here several different types of diseases that you think of, not only in neurology, but across all of medicine. Nutritional disease, infectious disease, toxic diseases, for example. And I could actually make an argument that MS is a disease that fits into all of these categories to various extents. So, nutritional disease, you might not immediately think of multiple sclerosis as a disease of nutrition, but then if I bring up the vitamin D story, it might ring a few bells that vitamin D deficiency is a risk factor for the development of MS. So, could this be a nutritional deficiency of vitamin D, a lack of exposure to vitamin D that results, at least in part, in the development of multiple sclerosis? I would say probably. Could it be an infectious disease? So I mentioned earlier that viruses dating back to really to the 1930s have been suspected as a possible cause of multiple sclerosis. And this idea persists with us to this day. No one's ever been able to identify a specific virus in the brains of MS patients that they think is the cause of MS. However, we know that certain viruses, such as Epstein-Barr virus, a virus that causes mononucleosis commonly, is extraordinarily prevalent in multiple sclerosis patients. This leads some of us to think that maybe that viral exposure early on in life down the road could play a role in the pathogenesis, the onset of the disease in multiple sclerosis. Could MS be a toxic disease? So the toxin that I mainly think about in multiple sclerosis is smoking, tobacco smoke, nicotine. We know both that smoking is a risk factor for the development of multiple sclerosis and a risk factor for the development of disability once patients are already diagnosed with multiple sclerosis. The good news is that if you quit smoking after the diagnosis of multiple sclerosis, your risk of disability essentially normalizes to the risk of someone who has never been a smoker. so it's never too late to quit. Genetics, another area of hot research in multiple sclerosis. So we've actually never been able to identify a single gene or a single change in one gene that all patients with MS have affected. In other words, there's no one gene that causes MS, and not everyone with MS has the same gene that's been altered. Nevertheless, we do know of many genes now that at least increase the risk of development by a few percentage points. This is important because we know MS can track in families, not like other diseases where you have, like a 50% risk of developing MS if a family member has it, but maybe like a 3% risk if one of your immediate family members has multiple sclerosis. And this is important to say because not in MS per se, but in other fields in neurology, we've actually come up with the first gene therapies. We're able to actually target the genes that are abnormal in the patients with those diseases. And maybe, in the future, we will be able to identify other genes that are more strongly linked with multiple sclerosis and target the MS at the source from that genetic basis. Now, these last three, inflammatory, degenerative, and autoimmune conditions, these are the ones that I typically think of as being associated with multiple sclerosis disease-modifying therapy. Our traditional disease-modifying therapies, and I'll show you a long list of these, target the inflammatory, degenerative, and autoimmune aspects of multiple sclerosis. And so while you can modify several of these other factors, traditional, at least medicines that we consider therapies for multiple sclerosis, target the inflammation, the degeneration, and the autoimmunity that is associated with multiple sclerosis. So just going through this list, can we modify nutrition? Yes, of course. You can supplement vitamin D. We know that patients who have a healthy, well-balanced diet and live at a healthy weight do better than patients who have an unhealthy diet. So nutrition is certainly a point of emphasis for us when we counsel patients about modifying their disease. Infection. At this point, we don't think that treating with antivirals or antibiotics really makes an impact in the disease course with multiple sclerosis. But again, in the future, maybe treating with a vaccine prior to the onset of multiple sclerosis might be a strategy to prevent multiple sclerosis, and that's an area of research and drug development. Toxins. Yes, we can modify toxins by quitting smoking, as I mentioned before. Genetics, not so much. We can't modify your genes at this point, but again, gene therapies are a hot area of drug development, and stay tuned in the future. But yes, inflammatory, degenerative, and autoimmune, these are the therapies, these are the areas of abnormalities in multiple sclerosis that we target with our disease-modifying therapies. So now that I've gone through what is multiple sclerosis, let's talk a little bit about the course of multiple sclerosis, because this impacts what therapies I recommend for my patients based on where they are in their disease and what their MS is behaving like. So traditionally, we separate MS into 3 disease courses. This model has changed a little bit over the years, but many of you will be familiar with the terms relapsing remitting multiple sclerosis, primary progressive multiple sclerosis, and secondary progressive multiple sclerosis. Relapsing remitting multiple sclerosis, as the name implies, happens in patients where they have relapses. And relapses really are those discrete events of worsening in multiple sclerosis. Typically, a new symptom will come on, last longer than 24 hours, and result in some kind of new symptom or some kind of new disability that then fades with time. Not to say that it fades back completely to baseline with time. Sometimes after a relapse, you're left with some residual symptoms. Sometimes you're left with a little bit of, trouble walking, trouble with the bladder, double vision, etc. Other times, you make a complete recovery and things go back to normal. Relapsing remitting multiple sclerosis has a relapsing remitting course where you actually make a recovery after each relapse, but over time you can develop some disability. Primary progressive multiple sclerosis, by contrast, you develop some disability or some symptoms right from the very beginning, even without relapses. So classically, these patients will describe slowly, year by year, that they're a little bit worse. Sometimes that worsening can happen actually quickly, sometimes it's very slow, and we think of it as kind of a smoldering inflammation that worsens year by year. And it's important to distinguish this pattern from the first pattern because we treat them differently, and we have different therapies that are good for that progressive disease, that slow worsening, that may also be good for relapsing disease, but not all therapies that are good for relapsing disease address that progressive piece. Lastly, there's this idea of secondary progressive MS. After 10, 15 years maybe of having MS, after your first relapse, maybe you don't have so many relapses anymore. And maybe you start to develop slow worsening either in between relapses that are becoming few and farther between, or you don't have relapses at all, and year by year you're starting to slowly feel that you're getting worse. Again, important to distinguish this from relapsing remitting MS because we treat them a little bit differently, and we have some therapies that are more appropriate for this phase of the disease than other phases of the disease. I might propose maybe an alternative model of thinking about the MS disease course. So really, if you're thinking about, where you are in your disease, you might think, well, am I in relapsing remitting MS, or maybe am I in secondary progressive MS, and how is that going to impact which therapies my doctor and I are going to pick for me? The good news is, or maybe not the good news, but another way of thinking about it is that you can break it down kind of purely into whether or not recently you are having relapses or whether or not the patient is having progression. And this splits out nicely into 4 categories. So you can say relapses yes, progression no. So maybe you've had a recent relapse, but in between relapses, you're doing okay. There's no discernible worsening that you're having at all. And that's one category. The second category would be you're having both relapses, and in between relapses, you're having some slow worsening. And that would be a different situation than no worsening in between relapses, and we might approach that differently. The third category is kind of the happy place. That's no relapses and no progression. This can often be a situation either where maybe the MS is very, very mild, which can happen, or it could be a situation where you are responding to disease-modifying therapy really well, and you're not having any relapses, and you're not getting any worse visit by visit, year by year. The last case number 4, is probably the most challenging to us as MS treating neurologists. These are situations where you don't have any relapses, but you're telling your doctor and you're perceiving and your exam is changing for the worse, slowly, year by year. Maybe your walking is a little bit slower from one year to the next. Maybe bladder symptoms are a little bit worse one year to the next. Maybe cognitive symptoms are a little bit worse. Your memory is a little bit worse one year to the next. And it's challenging because almost all of our therapies were shown to be very effective for relapsing disease. In other words, they all have been shown to essentially slow the rate of relapses in multiple sclerosis. There's only a few therapies that have actually been able to show that they have been able to slow the progression year by year of symptoms in the absence of relapses. So to take a step back, you're not always locked into categories 1, 2, 3, and 4. And these are just numbers that I made up to assign to these different situations. But year by year, you might switch from category 2 to category 1, or from category 1 to category 4, and we continually need to reevaluate which situation you're falling into, because that's going to impact which therapy we pick for your disease. So now I'll show you all the different therapies that we have for multiple sclerosis. And this is kind of an overwhelming list, but it's a good list in a way because we have about 20 different therapies that are FDA approved for multiple sclerosis at this point. And our therapies come in 3 general categories. There are injectable therapies, there are oral therapies, and there are infusion-based therapies. The first ones that came to market way back in about 1993 were the injectable-based therapies, the interferon betas of the world. And there are several of these interferon beta drugs on the market right now. You might recognize them listed on this list below: Avonex, Betaseron, Extavia, Plegridy, and Rebif. But these were the first ones to come to market, and they're injections under the skin. Glatiramer acetate, and there's Copaxone and Glatopa are 2 of the brand names for glatiramer acetate on the market now, are another injectable under the skin. Actually, the newest MS drug that's come to market is also an injectable under the skin, ofatumumab or Kesimpta. Oral therapies were the next class of medications to come to market after the injectables. These are drugs cladribine, dimethylfumarate, diroximel fumarate, monomethylfumarate, fingolimod, siponimod, ozanimod, and teriflunomide. They all have the separate trade names listed to the right there. And these differ in several ways, both in terms of side effects and safety profiles, and in how you dose them. So cladribine, for example, or Mavenclad is the other name for it, is a little bit different from the rest because it's not a daily pill that you would take. You actually do 2 courses of cladribine a year apart, and then per the label, you kind of reassess, but you can go up to 3 years at that point without redosing with the drug. The fumarates, Tecfidera, Vumerity, and Amphotericin, are all twice-a-day medications. The S1P modulators, Gilenya, Mayzent, and Zeposia, are all once-a-day medications. And teriflunomide or Aubagio is another once-a-day medication. The infusions are listed there on the right-hand column: alemtuzumab, mitoxantrone, natalizumab, or ocrelizumab, Lemtrada, Novantrone, Tysabri, and Ocrevus. Also differ in the frequency at which they're delivered. They range anywhere from monthly infusions to every 6 months, or in alemtuzumab's case, to an infusion that is similar to the idea of cladribine, where you're doing an infusion at point A and then point B 1 year later, a series of infusions, and then you follow up after that and may not need additional therapy for several years going forward. In general, and this is not a hard and fast rule, we tend to think of efficacy increasing as you're going from injectable therapies to oral therapies to infusion-based therapies. And by efficacy, I mean the ability that we have to shut down new relapses and shut down changes on the MRI. Again, there are exceptions to this rule, but that's kind of the way that we stratify these drugs. But you might imagine, as we are increasing in efficacy, all of these drugs work on the immune system, and so maybe their effect on dampening down your ability to mount an immune response against things like infections might be impaired as you scale up that list from injectables to orals to infusions. So it goes to the reason that maybe the injectables might be safer than the orals or the infusions. And again, exceptions exist to this rule, but I'm just trying to give you a general sense of how to organize these 20 drugs, because it can be overwhelming if you just look at the list of 20 drugs and you think, which of these medications is right for me at which point in my multiple sclerosis. What are the side effects? So this is obviously the first question that everyone has when I present this list of medications, or I present a few that I think may be appropriate for my patients. And the side effects really vary depending on which medication we're talking about. Each of them, you can look them up. They have their own set of side effects. But in general, as a class, our medications are very well tolerated. There are some concerns for several of our medications in terms of safety. And again, we have to watch things like your blood counts to look at the levels of your white blood cells, your lymphocytes, on many of our therapies. And we have to kind of monitor you for infections, both kind of common infections like urinary infections, colds, and more serious infections, such as you may have heard of things like PML, a potentially fatal brain viral infection that can happen with several of our therapies. Now, in my opinion, side effects are going to happen, but just because you're having side effects doesn't mean that we can't find another MS therapy that may be right for you. The good news is at this point, when we're recording this talk in October 2020, we have 20 different MS medications, more or less, on the market that we can pick. And we have a lot of different options, and I would say we have many options that most, if not all, of our patients find tolerable on a day-to-day basis. It's all about finding the right medication for you. What is the goal of disease-modifying therapy? So I've listed several quotes from my patients that I frequently hear. And it's important to note that the goal of disease-modifying therapy really is to come up with a medication that's going to treat the future you. So we're not looking necessarily to treat your symptoms right now. Treating your symptoms is important, and I believe we'll have a whole nother talk about treating symptoms in multiple sclerosis. But the goal of disease-modifying therapy is to prevent future relapses, future disability, and future MRI changes. You might tell me, I don't want side effects. That's a totally reasonable thing to say. What I would say is, I'm going to work with you. Let's find a therapy that you can tolerate. And, I can't necessarily promise that it'll be the first one that we try, but I can promise that eventually we will be able to find you a therapy that is both tolerable and something that is relatively easy for you to take. I want something safe. So, of course, we have safety concerns with many of our medications, but other medications are exceedingly safe. And as a whole, we always have to think about whether the safety of our medications, or maybe the safety concerns, are outweighed by the safety concerns of multiple sclerosis, because multiple sclerosis is a progressive disease where over time you can accumulate more symptoms, more disability. And so we always have to weigh the risk, really, of the safety of the medications versus the danger posed by MS itself. Sometimes my patients say, I don't want to have another relapse. I don't care. That was terrible. I just want to shut this down, and I don't want to, end up in the hospital again, have to go on steroids again. Maybe in those cases, we're a little bit more aggressive up front, where we go with something that, right from the beginning, we're trying to shut down MS and not have to cycle through a couple medications before we find the right choice. Then finally, sometimes patients say, I want to stop my symptoms from getting worse. So in these cases, we might, pick a drug that, is again, more highly effective. Something where we're trying to freeze MS at that point in time. Maybe picking a medicine that has been shown to have some efficacy for progressive MS to stop that slow worsening over the years. What do we look for in clinical trials, or what does the FDA look for when they're approving these medications? So in almost all of our trials, the primary endpoint, the first thing that we're looking for is whether or not these drugs stop relapses, or at least slow the rate or decrease the frequency of relapses when comparing, really in these days, to another MS medication. They also always look to see if our medications stop new changes from happening on MRI. So almost always the first endpoint of the trial, the first thing they're looking for is whether or not the medications stop relapses. And then the second thing they're looking for is whether or not only are they stopping relapses, they're stopping the MS from breaking through on the MRI. Almost always they're looking for these drugs to prevent disability, and sometimes they're even looking for the drugs to prevent progression, that slow worsening year by year. Because really preventing disability at the end of the day is what we're looking to stop. We can stop relapses, but if we're not stopping disability, then I would argue that we're not making, a big of an impact on MS as we could possibly make. Then the last two things that they always look for are tolerability and safety. Tolerability, meaning side effects when you take the medication. Is it causing things like a reaction to the medication? Is it causing upset stomach? Is it causing, any other symptoms that we need to watch out for? These are always looked for not only in clinical trials, but also after the drug comes to market. We're constantly doing surveillance about whether or not our patients are tolerating the medicine. So the last thing they look for, of course, is whether or not these drugs are safe. And actually every clinical trial is going to have safety endpoints. So they're looking to characterize not only whether some adverse events, some safety concerns are happening in these patients, but the rate at which they're happening. And this is very important so we can counsel our patients to be honest and be upfront when we're saying you're going to take drug X. Well, you have to know that the risk of this happening with drug X, whatever safety concern it may be, maybe an infection or whatever, is Y. It is a certain rate of things that can happen. This not only happens in clinical trials, but again, after these drugs come to market, we're constantly doing surveillance on them to whether or not these drugs are safe. What we can't promise at this point. So, like I mentioned, I can't necessarily promise that your current symptoms of multiple sclerosis are going to get better by starting therapy. These drugs are looking to prevent symptoms in the future to stop you from developing future symptoms of multiple sclerosis. Sometimes by stopping, the inflammation of multiple sclerosis, we can allow your body to heal naturally. But other times we have to use other therapies, symptomatic therapies, to address your symptoms. We can't necessarily promise that the first choice of therapy will be right for you. So oftentimes, as I mentioned, we try one therapy, and for whatever reason, there are side effects or it's not as effective as we would like it to be, and so we make a switch to another therapy. And of course, at this point, unfortunately, we can't promise a cure for multiple sclerosis. I'm optimistic that over the course of my career we are going to find a cure, and there are many people looking for a cure for multiple sclerosis, but our currently available therapies are not a cure. Do I have to be on therapy? And I'm going to add on, how long do I have to be on therapy for? And the answer is usually yes. Most of our patients with multiple sclerosis are on some kind of therapy for multiple sclerosis, but not all of them. And there are a couple situations that I can think of commonly where MS patients don't need to be on therapy. The first I would think of is maybe I'm not entirely sure that the patient has multiple sclerosis to begin with. It's their first attack maybe, and they've had one attack, they have some MRI changes that look like MS, but MS by its nature has multiple attacks, multiple events that happen, and you have to track the patients over time before you really are finally convinced that they have multiple sclerosis. But I would say really after you have that second event, that second relapse, that is when we definitely recommend, almost always, that those patients will be on therapy. Oftentimes after the first attack we start therapy to begin with, but sometimes we're a little bit unsure. In those cases we wait a little bit. The second case where you don't want to necessarily, where I don't think you necessarily have to be on therapy, is if perhaps there are some safety concerns with therapy. Sometimes, in patients who have maybe received chemotherapy or have had serious infections for whatever reason in the past, the risks of our therapy may outweigh the potential benefits. And then the other scenario where the risks of our therapies may outweigh the potential benefits, maybe if MS, maybe if at the patient's point in MS they're not having many relapses and they're maybe having maybe some mild worsening over the years, but after a conversation we don't feel that the side effects or the risks of therapy outweigh what the therapies can promise to do for the patients in that scenario. Oftentimes, we think about discontinuing MS medications after a period of time, 10, 15, 20, 25 years into the MS disease course. And this is a hot area of research right now because we don't really know when the optimal time is to stop therapy, but hopefully we'll be getting the readout from some clinical trials in the near future that gives us some more data so we can help you make the decision with your doctor when is the right time to stop therapy. So with that, I know I talked a lot, but I'll pause for questions, and I thank you for your attention.
I can comment a little bit about the different mechanisms of action. So some of these drugs are very complicated, and we still are learning things about how they work. So the common factor that they all have is that they all affect the immune system, but the immune system is extraordinarily complicated. Some drugs work by keeping immune cells out of the brain and spinal cord. We call those anti-trafficking drugs, things like natalizumab or the S1P modulators. Some drugs work by modulating the immune system subtly, so it goes from an inflammatory state to an anti-inflammatory state. Those are things like glatiramer and interferons. Other drugs decrease the body's ability to mount an immune response. It's almost like there's a threshold effect in which your body can mount a certain degree of inflammation, but we don't think it's enough inflammation to cause an MS relapse. And then there are other infusions and injectables, things like rituximab, things like ocrelizumab, things like ofatumumab that work by depleting a specific type of immune cell called B cells. So we have a lot of different ways to attack the immune system in MS, which is why it's challenging sometimes to determine which drug is the right drug for a certain person's MS, because MS is a very, it's a very different disease from one person to the next person, and oftentimes it's hard to predict which mechanism of action is best for each person. Yeah, so you're talking about kind of chronic infections, I think, in terms of can chronic infections be a cause of driving MS worsening? Great question. I think it's plainly obvious that acute infections, bladder infections, pneumonia, bronchitis, anything that causes a fever is clearly able to make old MS symptoms worse. Now, this is not a talk about relapses, but we would call that a pseudo-relapse as opposed to a true relapse, which would be inflammation from the MS that's causing essentially a new spot in the brain or the spinal cord or the optic nerve, causing new inflammation. Anything that increases your body temperature with a fever or even just walking outside on a hot day can increase the kind of almost like aggravate the old scar from the MS from previous attacks. Now your question is a good one. Can a chronic infection cause chronic worsening? You know, I wouldn't expect a minor infection like toenail fungus per se to be the driver of something like that. But if you have certainly things like chronic bronchitis or infections like that, I think that would definitely be a reason why overall your MS could be worse. Okay. Great question. So it depends so much on the type of cancer, the type of chemotherapy that you received, the drugs themselves. You know, it's really, and it depends also like how active your MS is at that point. Sometimes after a patient is treated with chemotherapy for cancer, we actually don't need to resume MS medications. And the reason for that is chemotherapy drugs have an effect on the immune system themselves that can be long-lasting. And the MS can be actually quiet after chemotherapy. Really, it's a case-by-case basis. I can't give you a specific drug. I think that would be best in that scenario. It really, really depends. But there definitely are choices that we think would be safe after treatment for cancer. Okay. So, great question. So, the whole point of contrast is to see if there's an active spot. In other words, is there a lesion that at the moment that you're in the MRI scanner is actively forming? It picks up only the lesions that are there maybe in the last 3 weeks or so. I would argue that if I'm looking, you know, sometimes we do like annual MRIs, and I want to compare one MRI to an MRI maybe 12 months ago. In those situations, I would not necessarily feel like I need contrast because I have a previous comparison, and I know that anything new on the MRI is new in the last year. So I typically only use contrast if I'm looking for a relapse, but even in that case, I'm not 100% using contrast in my patients. We do know that contrast dye, we think it's safe, but we do know that if you study brain tissue from patients who have gotten contrast dye, you can pick up some of that contrast deposited in the brain. We don't know what it's doing there, but you can be somewhat judicious nowadays about how much contrast we use. Phenomenal question. And then I think that's to be like the whole topic of a future talk. We're still learning a lot about multiple sclerosis and COVID. The problem is with anytime you're going with early data like this, you can make some false conclusions. And let me give you an example. Sometimes it's hard to say, based on what cases get reported, what the true incidence of complications is. In other words, there's a biases to reporting cases where something bad happens. The patient ends up in the hospital for COVID, or God forbid the patient has serious ICU complications or even death. The preliminary studies are encouraging, however, that we are not seeing a big signal in our MS patients by and large that if they do get exposed to COVID, that their COVID is worse than someone without multiple sclerosis. What we are seeing is that the same risk factors that drive complications for COVID, older age, obesity, diabetes, things like that, those are the things that drive outcomes and not the multiple sclerosis. Great question. Oftentimes this comes up in almost every new diagnosis of MS that we make. It can be a little bit overwhelming, I think, to look at the list of 20 different MS medications. Maybe you read about some of the rare side effects that can occur with these medications, and it's hard to put that in context. So sometimes there is, a little bit of skepticism about our therapies. And oftentimes our patients want to try something, like dietary modifications and things like that. There's never been any evidence that any particular diet or any particular pattern of vitamin supplementation or any evidence that exercise in and of itself alone is enough to modify the MS disease course. In other words, we know that all of those things together in combination with therapies are even more helpful than therapy alone. But I would be cautious with approaching, as you say, a kind of a holistic approach that doesn't include MS therapy if you and your neurologist feel that MS therapy might be necessary to treat your MS. That said, I don't think everyone with MS needs to be on therapy. There are certain people who have benign MS, as I alluded to in the talk, who could go 10, 20 years without having relapses or worsening of their MS. We just don't know enough about MS and diet and MS to recommend specific diets and exercise and things like that. to advocate for any one particular intervention. Yeah, so there are a couple areas that I am most excited about over the next 2, 3, 4, 5 years. One is repair. So I didn't talk about this for disease-modifying therapy, so repair drugs. The idea that you can have damage from MS and not just prevent future damage, but actually repair damage that's already been done. So it's a hot area of drug development, and that would be huge if we could do that for our patients. The second area that I alluded to in my talk is progression. A lot of MS medications have been studied in patients who don't have relapses but have some slow worsening over time. And some have had some modest success, but there have been no miracle drugs, I would say, for that scenario. Some promising molecules are in development right now, but I'm very hopeful that over the next 3, 4, 5 years we're going to have those drugs come to market. But we don't have, we are still waiting on the silver bullet, I think, for progression in MS. Yeah. So rebound disease is something we take seriously when stopping certain MS medications, one of which is Gilenya or fingolimod. I think we have a difficult time predicting who is going to have rebound. So rebound, for those of you who aren't familiar, is worsening of MS relapses out of proportion to what the relapses were like before starting the drug in the first place. So worse MS than ever before after stopping the drug. Typically, the thought is that the immune system comes rearing back after we had it active for a while. We've tried things like giving steroids after stopping medications that are associated with rebound. Unclear if that's effective. I would say, unless we have a reason to stop disease-modifying therapy, switching makes a lot of sense, and maybe not, maybe thinking about switching to another medicine that might have a preventative effect against developing that rebound. Makes a lot of sense to me.
Following up on that thought, the next question says, do you ever recommend that a patient use more than one disease-modifying therapy, assuming, of course, one could afford it?
Yes. So the answer is no, and that's a phenomenal question. I think maybe in the future that might be something that people look at. But the problem is when you combine therapies, remember, these therapies all have different mechanisms of action. They work differently in the body. And if you're attacking the immune system from too many different angles, you open the door, I think, too much for infections, potentially serious infections. So some of the rheumatologists for things like rheumatoid arthritis do use combination therapies, but we don't in the MS world. Great question. Yeah, and so I think that's a phenomenal question, and that's really kind of what interests, people like Dr. Serrano and I who are very interested in multiple sclerosis. We have to really identify what's the cause of multiple sclerosis before we can start thinking about what a cure is. And so I meant to be a little bit thought-provocative in the beginning of my talk, like breaking down all the categories that may contribute to MS, things like genetics, things like diet, things like viruses. In terms of a cure, one of the ways that people have talked about MS potentially being cured, quote-unquote, in the future is maybe cured by prevention. If we can figure out what causes MS, say for the sake of argument that it's a virus, by maybe having a vaccine against that virus, or maybe some other way of treating that virus before it can cause downstream implications for MS, that might be a way of stopping MS from happening to begin with. In terms of specific research, people are looking, they're really looking for what that first step is. Hot area of research in terms of genetics. There have been dozens and dozens of genes that have been identified that have some piece of the risk, but they're trying to figure out how those genes work together to increase the risk in combination with environmental things like vitamin D deficiency, like sex, like whether you're a man or a woman, like different dietary factors, smoking factors. We don't know how they all fit together, and until we really figure out how they all fit together, and that's what they're working on right now, that's how we're going to find a cure. Great question, and we're actually doing clinical trials to figure out the answer to that question at Georgetown right now. I think it depends on the patient. So I think there's no one-size-fits-all approach. Sometimes after if the patient has early aggressive MS, or they have a lot of early relapses, maybe relapses affecting the spinal cord, where we worry down the road that they might run into some disability from those relapses. And we worry that if they have one more relapse, they could end up using a cane or in a wheelchair or something like that. Those are reasons to certainly be aggressive up front. But there are plenty of situations where it's entirely appropriate to start low in terms of the therapies that have more modest efficacy and monitor closely, because we've had plenty of patients on quote-unquote low efficacy therapy, traditional therapies that do quite well in multiple sclerosis, and in those patients we never had to use things that are more aggressive. So it's totally a reasonable strategy, in my opinion, to start with more of a traditional therapy and then monitor closely, monitor the neurologic exam, monitor symptoms, monitor the MRI, and then step up in terms of being more aggressive after that. But like I said, we're doing a clinical trial where we're actually separating patients into two groups at the beginning, patients who are more aggressive with up front and patients who are more, patients who were more traditional with. And we're seeing which group is going to do better. So stay tuned, but the answer to that is still okay.
Margie has two questions. Is Gilenya the best and strongest oral medication out there for MS so far? Is it worth the side effects? So far, thankfully, after many years, my only side effect is low limbs. I was on Avonex first, and my neurologist wanted me on something stronger, so he switched me to Gilenya. Finally, does Gilenya makes us get COVID easier as it makes our limbs low?
Great questions. I think in terms of which MS medications within a class are the strongest, it's really difficult for us to say. The reason being is, with a few exceptions, MS drugs aren't compared head-to-head. So we know that, and the trials, when they're studying the initial trial for the efficacy of these medicines, we don't know, the patient populations in the trials are a little bit different. Sometimes they recruit sicker patients, sometimes they recruit healthcare patients. So comparing, fingolimod, Gilenya to siponimod, Mayzent, or to teriflunomide, Aubagio, or to dimethylphenidate, Tecfidera, is a little bit challenging because they're not directly compared head-to-head. In terms of COVID and fingolimod and COVID and Gilenya, we don't know all there is to know about MS and COVID, but like I was saying before, there does not appear to be a huge spike, especially with our oral medicines in terms of severity of COVID in patients on therapy. A little bit more of a difficult question to answer if somebody already has COVID, whether we stop the medicine, leave them on medicine, and we kind of make those decisions on a case-by-case basis. Okay. Sure. An amazing question. I just gave a resident at Georgetown here a lecture about this very topic today, talking all about MS in pregnancy, MS in nursing. And the answer is yes. So it's very important to plan pregnancy and plan a strategy with your neurologist, because there is no contraindication to having a normal pregnancy with multiple sclerosis. There's no reason why we can't. By and large, we do stop MS therapies during pregnancy, so we'll come up with a strategy to stop therapy prior to pregnancy. But how that strategy exactly looks is different on a case-by-case basis depending on how aggressive the MS is. In terms of nursing, in terms of breastfeeding, there are certain MS medications that are present in the breast milk and certain other ones that we don't think get into the breast milk at certain concentrations. So sometimes we do not recommend resuming therapies while the patient is nursing. Other times we do. It kind of depends on what the therapy is and how long we want to be off therapy. But in my opinion, there's no reason to discourage MS patients from becoming pregnant and after they deliver from breastfeeding for as long as they want to. There are clear benefits from breastfeeding, and we do know that MS tends to get quiet during pregnancy. So I hope that answers your question. Great question. So no. So what we have in MS is something called the clinical radiographic paradox, where some patients, they have MRIs that have a lot of spots, a lot of lesions, and very mild symptoms. And we have other patients with very few spots on MRI, and they have very severe symptoms. So it's hard to necessarily predict disability just by looking at the MRI. So sometimes with some of the fumates, you can have flushing as a side effect. Yes, we can prevent that. My first recommendation is that you always take the medicine with food. So if you like peanut butter, almond butter, or something like that, we typically would recommend that you take the medicine with food, both the morning dose and the evening dose. And just by having a little bit of something fatty, like peanut butter in your stomach, that really goes a long way to lessen some of the flushing symptoms and some of the upset stomach symptoms. There are also newer medicines within the fumarate class that have fewer upset stomach side effects. And so, just because you're having some side effects with one doesn't mean that all the fumarates cause that side effect. So, things like a diroximel fumarate has lower GI side effects, for example. So, my advice would be that you have that discussion with your MS doctor. Yeah, good question. So, for those of you who maybe don't know, Bell's palsy is a problem with the nerve that goes to the face that controls the muscles on the face, so there's some drooping on one side of the face. Usually we think there's some inflammation in the nerve. It's completely separate from MS, but MS can cause similar symptoms. So MS, if it affects the part of the brain that gives off that nerve, can certainly cause a facial droop on one side that may resemble Bell's palsy. Great question. MRI can tell the difference. With the Bell's palsy, you're not going to have a spot in the brain. So there's no findings within the brain itself. It's more of a problem with the nerve after it's left the brain. In my opinion, there's never been any one specific diet that has been definitively shown in clinical trials to necessarily modify MS disease course. That said, anecdotally, we hear from patients who feel better after all sorts of dietary changes. So I wouldn't dissuade you, but I can't endorse any specific diet. Great question. And I think, the historical answer to that question is yes, by a few years. And I think part of the reason for that is a lot of the life expectancy questions in MS come from the era prior to treatment, where we didn't have patients who were treated with MS from the very beginning in some cases. And so you can imagine as you develop some disability off treatment, maybe you end up using a wheelchair or not able to have mobility. That can make you susceptible to things like pneumonia and things like that may have had historically an effect on shortening the lifespan. I counsel patients when they're diagnosed with MS in 2020 that I expect them to have full, healthy, productive lives. So I think that if we were to repeat those studies now, I would not expect to see much of a difference. Well, I thank you all really for your attention. I appreciate you spending tonight with me. My name, for those of you who didn't catch it, my name is Brian Berry. I have an MS clinic under the umbrella of MedStar Georgetown, but it's physically based at MedStar Washington Hospital Center. So I am always happy, if your doctor wants a second opinion about multiple sclerosis, or to see you and to help you along your journey. And I thank you for your attention.